Good morning. Good morning. Thank you so much for being here today. It is a little bit of a change. I don't know if you guys can tell the background here, but I'm actually not at home. I am in Tulsa, Oklahoma, visiting my daughter, who is living here in Tulsa. She just moved here from South Carolina. I have a little bit of a frog in my throat this morning, so please forgive me for sounding a little ragged and not so awake. We were at a wedding yesterday, and I'm super excited to be here. I'm not sure if my comments are going to come up on the screen. Good morning, Miss Cheryl. Yay, I'm so glad you're here. I have my handy dandy list of questions, which I had to write out because I'm not home and I couldn't type them out and print them. So thank you for joining me, Cheryl. I'm glad that you're here. I am in sunny, very, very sunny Tulsa, Oklahoma this morning, and we went to a wedding of a young lady that we saw get literally grow up in front of us. So I'm very excited to be here. Today is July the 24th. It is 2001, and excuse me, this is the Baffled Brain, Demystifying Dementia, where I come to you once a week for an hour to answer your questions. And I do love to answer questions live, so if you have questions, please throw them out. Miss Cheryl, who's on here, actually had some really good questions, and I thought I would start with those. So right at it we go. I hope you guys can hear me okay. I don't have my usual sound stuff, which I use my husband's, but I will be getting better at that as time goes on. So Cheryl actually had 3 questions, and we'll kind of go through them. And Cheryl, I'm going to ask you some questions about your questions because sometimes it makes a difference in where people are. And I believe, if I remember correctly, your mom is at an assisted living memory care, not a skilled nursing, correct? So Cheryl's first question is, how as a POA do we get more information about when the facility doctor needs to see my mom and the outcome of those visits? So how, as Cheryl's her mom's POA, how do I get more information from either when the facility doctor needs to see mom and the outcome of those visits? So Cheryl, your mom is in an assisted living, not a skilled nursing facility, correct? I think that's what I remember. So it really does make a difference whether a person is in a assisted living versus a skilled nursing. So they actually have totally different rule sets. So in a skilled nursing facility, the physicians are required by law to see a patient 1 time a month. Okay, so the skilled nursing puts people on a list that once a month they see the doctor. If something happens in between, the nurses request for the doctor to come see their loved one. But in an assisted living falls more under independent rules. It's kind of halfway in between living independently, where you're entirely in charge of all of your own things, doctor's appointments, etc., and a skilled nursing facility. It falls under a totally different rule set. I'm not entirely sure, because it's been a while since I actually worked in in assisted living, whether they're required to see somebody once a month or not. It would seem to me to make sense that they do, but at the same time, they may be falling under the rule set of being more independent, and that, like my parents who live in independent living, they go see the doctor once a quarter. So every 3 months they go see the doctor. It may fall more under that purview, that the physician is more there to be able to handle things that come up in between, and that, like, for example, the nurses that work at the assisted living, if they see mom has had a sudden change in something, that they put her on a list for the doctor to come see then. The best way, I think, to handle these things, Cheryl, is you need to be... So I always tell people, and COVID really changed things in facilities, and I know we're kind of getting out of the whole COVID mess, or mostly out of the whole COVID mess, but I'm sure COVID has had an impact on assisted living and skilled nursing facilities. pretty significantly regarding these types of things, because normally, under normal circumstances, if I had people that I was referring to an assisted living or a skilled nursing facility, what I would tell the family members is, you need to be there and not on a routine. And what I mean by that is, I want you to routinely go see your mom or your dad, but I don't want you to be predictable. So for example, don't always go see her Monday afternoon, 5 o'clock, same time, same place every week, because then the staff over time start to see your pattern. They see your routine. So Monday afternoon, 5 o'clock, guess what? Mom's always going to be ready, right? You want to go to a facility, any facility, whether it's a nursing facility or an assisted living facility, memory care. You want to go random times. You don't want to have a very set, repetitive routine where you don't deviate from it. You want to show up at 9 o'clock at night. You want to show up at 4 o'clock in the morning. Maybe not 4, but you understand what I mean. You want to go at various different times throughout the day so that you can literally be her eyes and ears, so that you can see what the staff are doing. You don't want to only go there between the hours of 8 o'clock to 5 o'clock Monday through Friday. Why? Between 8 o'clock to 5 o'clock Monday through Friday, that's when the facility, any facility, is the best staffed, right? That's when you have maintenance there. That's when you have all of these other disciplines, activities. We'll talk about activities in a minute. That's when you have all sorts of people coming in and out, lots more activity, lots more engagement. And so it's very easy for everybody to be fairly well, not necessarily well cared for and well looking, right, during that period of time, because there are a lot of people in and out. You want to go 7 o'clock at night. You want to go 9 o'clock at night. You want to go 6 o'clock in the morning. You want to go all sorts of different times, and you don't want to have a routine, because then you get to see all the different shifts. Every facility works a little differently. Some facilities staffed 3 shifts a day, right? 3 8-hour shifts. Some facilities staff 2 12-hour shifts a day. So you want to get to know the staff on all of the different shifts. And your best friend in a facility is the PCT or the CNA. You want to get to know your mom's PCTs. You want to get to know the people who are frontline taking care of her. Oftentimes in an assisted living, they use med techs, and med techs are CNAs and dispense medication, and an assisted living will have access to a RN, but the RN isn't necessarily, well, I think typically the RN is on in the facility at all times, but they're not actually necessarily, like in a nursing home, the skilled nurse is actually dispensing the medication, doing the treatments, etc. So assisted livings and nursing homes have a lot of different types of rule sets. So knowing the rule set of where your loved one is, which your mom's in the assisted living memory care, really does help. Now back to your question, how as a POA to make sure that they get more so that the facility doctor can see mom more, is you need to find out, first of all, what is the rule? What is the rule about how frequently that doctor needs to see your mom? If it's a once a month thing, you need to find out what the schedule is. When's my mom on the schedule? And then on those days, you want to maybe try and say, okay, I'm gonna go visit mom during that period of time when the doctor's supposed to come. So that is definitely where I would start. I know you had a follow-up question, so I'm going to answer that one right now. And do I recommend using the facility doctor or the one outside, and why? So Cheryl, that is a really good question too. So there are pros and cons. Yet again, it also depends on where a person lives, right? So in a nursing home, I think it is beneficial to use the facility doctors, because they are there every single day. They have nurse practitioners, they have PAs, whatever. The people, there's a lot of, like every time I've worked in a nursing home, the doctors would come around every day. They don't see every patient every day, right? They come The facility has 5 wings. They maybe see wing 1 on Monday, but if there is emergency, or things that have changed with other residents, they'll go see them while they're there. Or the doctor will round on certain people and the PA will round on other people. But the facility will keep a list, say, Auntie Annie had a rapid change in her thinking overnight. Can we test her for UTI? Okay, so in a skilled nursing facility, I think having the skilled nursing facilities physicians be the ones who oversee mom's treatment be a lot more important. Now, in an assisted living, so there are pros and cons, right? So if your mom has so frequently what happens is the facility doctor will take over the primary care type of role. Routine things like, UTIs, or her blood sugar's out of whack, or all sorts of other very routine things. And the specialists still stay intact as part of the team, right? So her neurologist wouldn't change if she had a rheumatologist or any other physician, right? Any specialty doctors. So where you have to weigh the pros and cons, it starts to become, with people with dementia over time, it becomes harder and harder to take them out of the facility for a lot of variety of different reasons. Number one, their mobility starts to be a little bit more of an issue. So if it's starting to be more physically harder to get her in a car, out the door, to the doctor, back and forth, then it becomes more important or easier than perhaps to use the facility doctor, right? So if your mom is still at a point where she is easy to move and it's not difficult, and by that I mean behavioral, right? If it's not behaviorally impacting her to leave the facility and come back, there are lots of, you'll have to kind of feel that out a little bit, because maybe at the beginning, she just, I know based off of the timeline that you and I spoke, that this has been a recent change. So you're going to have to try to take her out and see what happens. And if it changes your mom's behavior, in other words, what I mean by that is you take her out and then she's wild and woolly for the whole rest of the day because her brain's saying, woohoo, I can't take this, then you may want to consider not taking her to those doctors and just using the facility doctor. So every person's different, and every person, you kind of have to try things. And I know it's not a great answer to say you got to try different things, but you literally have to try different things. And then you also don't necessarily know it may work today, and then 2 weeks from now it may not work anymore. And I'll use an example. I'll use a patient that I worked with recently as an example. I started working with them as an occupational therapist in their home. And when I started working with this gentleman, so my history is I have a fun history. I've worked all over. I've worked in assisted livings, I've worked in nursing homes, I've worked in hospital settings, I've worked in home health, I've worked in outpatient, everywhere. But I work at a hospital system where I did half my week, half of my day was in the hospital, in the acute care hospital. Somebody fell, broke their hip, I go in and see them. And home health. And I distinctly remember, I have a really good memory of seeing this gentleman in the hospital many years before, but now I got him as a home health patient. And so we got there, and the family was like, we want to take him to see a neurologist. We're trying to figure out what type of dementia he has. We're thinking he has Lewy body dementia, but nobody's ever told us, etc., etc. And he was pretty mobile when we started. And I had a conversation with the family where I said, if you want to take him to a neurologist, that would be fine, in order to find out what type of dementia he has. He was still pretty mobile, but he had an event in between. So I saw him for about 6 weeks. And I saw him for about 2 weeks, and when I first started seeing him, I could walk him, handheld assist, from the bathroom. We gave him a shower. I helped him take a shower, and we got him handheld assist back to the recliner. Had lots of behaviors, lots of hallucinations, lots of other things, and the daughter really wanted him to be seen by a neurologist to determine whether or not he had Lewy body dementia versus a different type of dementia. Well, after about 2 weeks, he had a medical event. Something happened, and I'm pretty confident that he had urinary retention, which turned into a UTI, and they took him to the hospital, and he literally crashed and burned on us. And what I mean by that is, they took him to the hospital, the change, the infection, everything, and he went from ambulatory talking to non-ambulatory, and the hospital said, well, you need to take him home and die. Literally. I'm like, what? And so they came back to me as they were readmitted under home health. And the daughter, we had a conversation, and I told her, I said, we have about 3 to 4 weeks to see if he's going to rebound. And so we kind of gave it a couple weeks, and after about 3 weeks, I'm like, yeah, no. But in that period of time, back to the conversation about the doctor and taking somebody out to the doctor, she had to take him to the urologist. And she took him to the urologist, and it was a 4-hour ordeal. He has severe end-stage dementia, urinary retention, a catheter, got totally behaviors, sitting in a waiting room for 3 hours. 3 hours. So back to what you were saying about a facility doctor, Cheryl, versus a outside doctor, and why. That's why you have to sometimes try to see, because at the beginning it may be still appropriate, and it doesn't change her behaviors, and it doesn't change the impact of the rest of her day. I have a rule. I have a rule that I made for myself many years ago, right? If what I am doing as a therapist, as an occupational therapist, I go in, I'm the OT, right? I know what I'm doing. I go in, but what I'm doing makes it worse for the nurses for 24 hours afterwards, I'm not going to do it. Because I don't want to make things worse for the staff that are taking care of somebody in a facility. So if you take your mom out to a doctor or somewhere, and she comes back to the facility and she is cuckoo for Cocoa Puffs for 12 hours because her brain's all, not there with doing this, and we've made it so hard for the staff to manage her for 24 hours afterwards, I don't think it's worth taking her out. And then I don't think it's worth taking her to an outside doctor. But you have to kind of figure that out over time. So you have a follow-up question as mom's power of attorney. Do you have a right to her medical records of the facility doctor? I believe that is a yes, but remember there are 2 types of power of attorney. And in order for you to, you have to be the healthcare power of attorney on top of the financial power of attorney. So if you're her healthcare power of attorney, you do have a right to her medical records, etc. I would caution you to be maybe careful about trying to figure out if you can find another way of getting the information without pulling that card, just because you want to develop a good and close relationship with the facility that you have your mom in. And so if you can, good, so you have medical and financial. So if you can backdoor it, anytime we can backdoor it, your best. So what I always say is make best friends with the PCTs or the med techs or whatever they are at her particular facility. They are your best friend. You go in, you love on them, you talk to them, you try to, what's the word I'm looking for? You try to praise them, find the things that they're doing well, make them feel good about themselves, because then they are going to take care of your mom even better than they should be. I mean, they should be taking care of your mom, I understand that, but this is a difference. So a PCT, as a med tech, they're your best friend. You don't want to, excuse my French, you don't want to piss them off. You want to make sure that they are the ones that you are talking up. If you find good things that they've done, go tell their director. Go talk them up. As much as you can talk up a facility, they really, the people eat that up. So that's what I would do. And so, yes, you do have a right to her medical records. I totally understand that. But let's see if we can find a different way of getting it and just saying, hey, what's going on with mom? Squeaky wheel does get the oil, but you want to be, so a good example I'm going to use, my daughter was in the ICU once. She was about 14 years old. And I always used to say, And this is really interesting about me. This is just an aside about me. I always used to say, if something happens to one of my loved ones, I'm going to be hell on wheels. Because I'm like, I know everything. I want to know what's going on. I want to be in charge. That's, I'm going to be the mama bear, right? And so my daughter had a gastric bleed. Sudden, very sudden at 14. She had 2 ibuprofen 2 times. Once on a Tuesday and once on a Thursday. But she wasn't feeling well, so she didn't eat. And she had these nondescript symptoms. She was cold. I don't feel good. I'm tired, and I'm like, you're fine, whatever. Well, one of the ibuprofen had landed on a spot on a blood vessel in her stomach, and at 14, she was laying on her bed upstairs. We had a double-story house upstairs, and she was laying on her bed, and she got up, went to the bathroom, and puked a whole bunch of bright red blood. And my husband, she passed out, got up, got to the bed, went to the bed and passed out again. And my daughter almost died because she passed out again on her bed from blood loss. Woke up with just enough energy to call her dad, who was downstairs in the house. Called her dad and said, "Daddy, I need help." And he kind of, what's going on? Walked up the stairs, and she said, just go look in the bathroom. And he went into the bathroom, and the entire white bathroom was full of blood. But he called me, and anyway, to make a long story short, she ended up in the ICU. And, going back to what I said, I'm going to be hell on wheels if something happens to one of my loved ones. I walked into that ICU, and I had a realization. I'm like, I want to be the one that they are going to love. I don't want to be the one that's critical and nasty. I want to make their jobs as easy as possible. And I just I'm like, I was just very, very calm, very collected, very thankful. And you know what? My daughter got the best care possible. So just when you're working with your loved ones in a facility, I would encourage you to, you will get more bees with honey than vinegar. You will get more out of the facility and out of the staff by being sweetness itself, as opposed to going in there and being a hellraiser. Because trust me, working in places, if you're the hellraiser, they see you coming, they want to get out of your way. So that was just an aside, Miss Cheryl. Let's see what Miss Diane says. Diane says, my sister said yesterday that her memory isn't as good as it was, and said that she was told she has Alzheimer's. Then she said, but I don't think so. How should I reply to her? That is a great question, Diane. Thank you so much for asking that. And I am so sorry to hear that you just heard that your sister may have dementia. It is devastating. It is very devastating to hear somebody you love has dementia. It's hard. It's very hard. So I'm super sorry for you about that. So my question to you would be is, what do you think? Have you noticed that she's having these changes? And if you have, kind of how long have you noticed them? So Diane, what I would tell you is that there is and I struggle to say this word, so please forgive me. There's a condition that's very common with people with Alzheimer's called, I can spell it and type it, but I cannot say it. Anyway, I will type it in the comments afterwards. Agnosocia. I literally cannot say the word. But what it means is that it's not denial per se, they truly just don't understand it. And it's a physical change in a person's brain. So it happens in a variety of conditions. It happens in things like schizophrenia. People who've had strokes get this. A lot of mental health type of issues have this, and it's as a result of the physical changes in the brain. It's literally not the person sitting there and saying, I'm in denial, right? Everybody knows the Kubler-Ross 5 stages of grief, right? It's denial, anger, bargaining, something I can never remember, and then acceptance. And so when we think about people who are in denial, right, that's a protective mechanism from what's going on. It's like, I truly, this didn't happen, it's not happening. So people who have Alzheimer's, though, because and a lot of other conditions, because there are physical changes in the brain, they don't, they really don't understand what's going on. And how you reply to her is just by going to the emotional behind it. It doesn't help arguing with somebody with dementia. It doesn't help arguing and saying, but you do. And I will say, I'm a therapist. I'm an occupational therapist by background and training, right? My mom has vascular dementia, and I will tell you, it is extremely hard, even for me. And my husband, he's actually getting really good at this. He's like, why'd you argue with her? Why'd you try to reason with her? Because it's my mom, she was always able to. And so it's easier for me, and it's been very interesting because, I've been a therapist for 30 years. My mom had a stroke when I was 19 years old, and I'm 50. And so I've kind of walked this walk with her for decades now, for almost 30 years, right? And she's had these changes that are definitely vascular dementia, and I, am now in the role of, I'm a professional, but I'm also a daughter of somebody who has dementia. And so it's been very hard for me. It's been truly hard for me to be able to realize that I shouldn't argue with my mom. So back to your question, how should you reply to her? Try to go to the emotions. Try to go to the emotions behind what she's saying, but trying to reason it through with her is not going to help you. All it will do for you, Diane, is really frustrate you. It's just going to, because she's not going to get it. She's literally not going to get it. So you just want to say, I'm sorry you feel that way, or, maybe redirect her. There are a lot of different things you could try. But if she has been told that she has Alzheimer's, if you are one of her primary support people, my best advice to you is to start to really educate yourself about what dementia is. I would encourage you to join my group. I have a private Facebook group called Think Different Dementia Education Group, where my primary purpose is to do education. It's a supportive group. I'm not saying it's not supportive. It is supportive, but it's not a support group. It is an educational-based group where I use my 30 years of occupational therapy to help people who are supporting people with dementia or people with dementia themselves in being able to navigate this journey that they're on. So, Diane, if you're not part of my group, please join my group. That would be wonderful to have you there. I do a little hour-long topical program once a week. I try to stay on target. I mean, I'm human, so I don't always get, I've been sick, and I've traveled, so sometimes it doesn't happen, but that is definitely an invitation to you, so I hope you take me up. And then, so I have two more questions that I'm going to try to get to here, and I have several more actually, but you are welcome, Miss Diane. I hope that was helpful. I would, if Miss Cheryl is still on here, Miss Cheryl has another question, and that had to do with activities. So how to assess activities and if they're occurring, and what to do if they're not. So Cheryl, that kind of segues back into what I said at the beginning about the facility, right? So here's a little known rule, something that as care companions, as care partners to our loved ones, that we need to understand is that there are very strict rules in facilities. There are very, very strict rules in facilities. Like in a skilled nursing facility, Ms. Cheryl, what I want you to do is I want you to go, get from the facility. Now, I know when you took her in that they gave you a whole bunch of papers, right? And we have a propensity of not necessarily reading through those papers necessarily at that time, because it's like information overload, right? So you probably got a piece of paper, and if you didn't, then you ask them, where is the document that says what are the rights and responsibilities of the residents? Okay, because there is a document that has the rights and the responsibilities of the residents. They have resident rights, and one of those rights is the right to refuse. Okay, so it kind of sounds counterintuitive, but a person still in a facility, even in a skilled nursing facility, has the right to refuse. And where that comes into play oftentimes are things like activities. So for example, they will have a calendar of activities. Monday is bingo. Don't mess with bingo. Don't ever mess with bingo. Everybody loves bingo. I don't get it. But anyway, most people love to go to bingo. And so I would go get the calendar every month. They get a calendar. It should be posted in her room, or it should be on the unit. I would ask for a calendar of activities. I would sit with my mom, and I would try to pick out the things that that she might have actually enjoyed doing. And then maybe at those times, if you're able to sporadically go and actually take her to an activity, you'll be able to see, are these truly occurring? Because the staff will come up to mom and say, do you want to go to bingo? And if mom says no, they can't make her go. Now, there are tricks and things that I teach care providers or staff in a facility to not go and say, do you want to, right? Because if I say to mom, do you want to go to bingo? And mom just automatically says no, but she really probably would have enjoyed it, I'm up a creek because mom said no. So I always teach my care partners and care providers that I'm working with, like formal care providers in a facility, to say, it's time for bingo. Let's go to bingo. Come with me, right? So I would get the calendar, right? So how to assess activities are actually occurring and what to do if they're not. So the first thing is the rights and responsibilities of the residents, because if she has the right to refuse, and then you want to kind of figure out how are they actually asking her, or how are they bringing people to activities, or do they just have these activities and the person just needs to spontaneously go? Each memory care looks a little different, right? So some memory cares have whole apartments, right? So the person goes back to their apartment, the door is shut, and then if they're not spontaneously going out to activities, then they may not be engaging. So you're going to kind of have to do a little bit of homework on your side to figure out, is she able to, are they just leaving her in the room? Do they actually ask, ask them, are you going and asking the residents, do they want to come to these activities? How are you engaging people in these activities? I see you have this list of wonderful activities. I'm so thankful for that. But I want to know how do we get my mom to actually engage in these activities? What do we need to do? What plan can we come up with, right? Try to walk next to them and facilitate it from behind, and not just from you're not doing it, right? Because if you more likely somebody is there attempting to do these facilities. More likely, I will say, like I said, COVID changed a lot. My hope is that these activities are still being facilitated, but we got to figure out how the facility is. I've worked in facilities where they literally go knock on every single door when the activity is occurring, and say to people, "Come, let's go. It's time for the activity." So I know that was a lot. I know that may not have been a complete answer, but I would encourage you to start there. It's going to take the facility a good 6 months to really get to know your mom and your mom's preferences and desires and things like that, okay? So does anybody on live have any follow-up questions? Ms. Cheryl, do you have a follow-up question, or Diane, or anybody else who has been out here? I would love to hear from you guys. If you're watching this live, thank you for being here live. If you're watching this on the replay, just put replay in the comments. Let me know you were here. I would also invite you, if you're not a part of my group, it's called Think Different Dementia Education Group. I do an educational program once a week on a topic. I've gone through things like incontinence. I've gone through staging dementia. I've talked about hospice care there before, lots of different things. And so I would love to invite you, if you watch this, if you like what you're seeing, please join us at Think Different Dementia Education Group. And Ms. Cheryl, I heard from the CNA that the activity calendar I was provided wasn't for the assisted living memory care, and they only do 2 to 3 activities a day and not the 6 to 8 listed on the calendar. And the director is telling me they do the activities on the calendar. So probably, so is it, so what I understand from what you're saying is that your mom lives in what we call a continuing care community, so there's probably a skilled nursing and an assisted living. So I would start with giving them some grace. She's not been there for a very long time. That I would look at the activity calendar, look at it critically, because sometimes they will have, like on the calendar, I've worked in facilities where the activities calendar would specify, but it's very small and maybe in code, that this activity is actually at the skilled nursing facility and this activity is actually at the memory care facility, right? So I would critically look at the calendar and try to see if you can discern whether there's like a location that they have put that the CNA is possibly correct, that there are 6 to 8 activities listed, but primarily most of the activities are at the skilled nursing facility. So I would look at it that way. I would give them grace for 2 reasons. Number one, most facilities are just getting back up to speed after COVID. COVID was devastating. COVID was devastating in a facility. People couldn't come out of their rooms. They couldn't, they had to take one-on-one activities to people. It was very devastating. Number two, your mom has only recently moved in there, and it's probably been from, if I remember from when we talked, less than 2 months, right? So I would give it a good 6 months. I would stay on top of it. I would definitely be active in the facility and in her care. I would take the calendar and I would try to go during some of the times when there are supposed to be some of these activities and just kind of watch. You want to be a dementia detective. You want to be, so when you turn into your mom's advocate, your mom's loved one, right? Your mom's your loved one, so you turn into her eyes and ears. And that's why, circling back to what I said at the beginning of the program, that's why you go at a variety of different times. You don't just go at the same time every single day. So Miss Diane says, speaking of activities, what can you do at home? My sister does not have much of an attention span. It's hard to keep her engaged in anything for more than a few minutes. So that is very true. The longer people live with dementia, their attention is one of the first things that go. And it can make it very challenging. And that's why it's important, when sometimes people ask me, why is it important to know what stage of dementia a person's at? Because each stage of dementia has lots of different things that are very characteristic to them. So Diane, if you joined my group recently, I can't remember, Tuesday, I think it was on Tuesday, because I'm in Tulsa and I'm here for a wedding, so my routine's a little out. And it kind of brings up the fact that when our routine is out, normal people like me, I'm fairly normal, mostly normal, we have a range of cognition, and I'm in a new environment, I'm tired from the flight, we've been very busy, so I'm not thinking my clearest, right? And I don't have dementia, at least not as far as I'm aware. So knowing what stage of dementia your sister is important, because each different stage has different attention spans. And so I would encourage you to join my group so that you can watch the program on the staging of dementia. I use two different methods of staging people. One is called the functional assessment staging tool. And the reason I like that, Diane, is because it is it's a retrogenesis model. Retro means from behind, right, or old. Genesis is from the beginning. So back to the beginning, retro back to the beginning. And the functional assessment staging tool is a staging tool that uses the model that people are going back to the beginning. So it is based on developmental milestones. We all know, most of us have seen children grow up. Everybody goes through certain milestones as they're turning into an adult, right? And then as people are going through the stages of dementia, there's a fairly consistent regression, if you would, fairly consistent pattern that most people follow. Not everybody follows this, and sometimes people do, have an event that happens, an acute event, and then boom, they stage down. But knowing what type of, what stage your sister's at, will make it easier for you to be able to pick appropriate activities. So what are some appropriate, what can you do at home? Number one, you want to remember that you want to try to find things that she would have been attracted to do before. And oftentimes people still have the desire to do things, they just lose the ability to initiate to do things. Sometimes people, their interests, and actually this is interesting because this kind of segues into what Lisa Robin, I use people's first names, not typically last names, I'm sorry. Lisa asked on here, my dad used to love to eat and do certain hobbies that he no longer likes. Is that typical? And yes, so Diane, yes, people's interests change. All of our interests change over our life, right? Our interests aren't static. We aren't static beings. We are dynamic beings, and we engage in our environment. But you can always find things, literally almost anything that we do, and this is what makes occupational therapists, if they are good occupational therapists, this is what makes us be who we are. I can walk into a room and I can take almost any activity and I can make it harder or I can make it easier. And so everything that we do, whether it be folding laundry, whether it be sorting knives and forks, whether it be anything, you can make it harder or you can make it easier, right? So let's use laundry as a task, right? So how do you make a laundry task harder? You make a laundry task harder by having to do everything. You have to go get the laundry, you have to sort it into different colors, you need to take it to the washer, you need to put in the right amount of soap, you need to choose the right cycle, you need to switch on the machine, you need to remember 30 minutes, hour later, whatever, to take the laundry out, put it in the dryer, choose the right stuff to put in the dryer with it, choose the right cycle and time. Remember after that time to go back out and get it, correct? So that's the hardest laundry task. So what's an in-between laundry task? I, as the care partner, do everything. I take all of the laundry out and I give them the whole bundle of laundry and tell them, please help me sort and fold this, right? So big pile of laundry, now I have to take a t-shirt, know how to fold a t-shirt. I need to be able to take the pants, fold them. I need to choose what needs to get hung up or not hung up. The whole bowl, big bundle of socks, now I need to choose. I have to pair them, I have to choose which ones go together, and then I have to roll them. Okay, so that's an in-between one, right? So how do I make that even easier? Okay, so I can give the person just towels and say fold the towels. And then I could care less how the towels are folded, right? So the engagement becomes the task and the quality goes away. So at the higher level of the laundry task, right, we don't we are looking for quality. We are looking for ability to sequence and follow through, etc., etc. At the mid-range, I'm still looking for quality. I'm still looking for some discernment. I'm still looking, but I'm starting to make it a little bit easier so that the person can be successful. I want them to feel success, but I'm not as much worried about the quality. So, even if I have to stand there and I just put everything into different piles and then they fold those up, right? In the latter stages where I'm just folding towels or washcloths, I don't care what it looks like when it's folded. I just want the person there being engaged in the activity. I will take the stuff later on, I will move it out of their sight, and I will go fold it if it's that important that it's folded in the right way. So activities can be made, all activities can be made harder or easier. If your sister doesn't have a long attention span, then what you want to try to maybe start to do is come up with 4 or 5 boxes of things, of activities that you put in different boxes, kits, for lack of a better word. There are things that you can do. I actually think you can buy some dementia activity kits. I haven't researched that lately, but I think you can. But what I would do is I would just get some Tupperware boxes, and I would find some things that she would normally, be engaged in. And the reason I say make kits is because if attention's a problem, if you just have something you can go take out and do for a bit, like for example, a box with things that can be sorted, easy things that can be sorted. It can be things like blocks of color, where you can just sort. I want you to put all the reds together. I want you to put all the blues together. I want you to put all the yellows together, right? Just sort colors. How do you make that harder? You have 6 colors. How do you make that easier? You have 2. How do you make that even easier? You give 2 colors and say put all the red ones back in the box. So there are lots of different ways that you can find activities and activity kits that you make, pre-make, that you have so that you can pick out and you can go and say, here are 2 kits, okay? One has this, one has this. Which one do you want to do today? And then you just do it for as long as she is engaged, and then you move on. And it's okay to move on. It's absolutely okay to move on. So Lisa, back to Lisa's question. So that kind of Diane and Lisa's question kind of work together. Back to Miss Lisa's question, where she said, my dad used to love to eat certain things. So let's talk about that for a minute, because she asked, so we talked about activities, hobbies that he no longer likes. Yes, these things are typical. Absolutely, they are typical. But what happens regarding the eating, Miss Lisa, is the following. As people go through this journey, their taste buds change. I need to take a sip of water, excuse me. As people progress through dementia, through the stages of dementia, their taste buds actually change. They lose, we have 5 salt, sweet, bitter, sour, and I think something else I can't ever remember. But anyway, our taste buds change, and people with dementia lose some of the ability to taste certain different salt, different types of things. And what they end up only being able to taste are things that are sweet. So that's why they like sweet things. So here was a trick that we learned in a nursing home, that I learned in a nursing home from the staff in the nursing home, right? How to trick people who have later stages of dementia to actually eat. And it's disgusting to me because I know what I'm doing, but at the same time, if it'll get the person to eat, I don't care, right? I want them to eat, because the latter stages of dementia, weight loss is a significant problem. People lose their appetites, people lose their ability to feed themselves, so they don't eat as much. People lose their ability to taste. So as all of this stuff is regressing, right, according to the functional assessment staging tool, as people are going through this progress and they get to the point later on where all of this stuff is starting to come together, and then there's a tipping point between knowing what a tool is and not knowing what a tool is, and that's the tipping point for where people need to be fed. So the reason I say that is, like, one of the things that I as an occupational therapist will do immediately when I go see somebody with dementia is I will try to give them something to hold. I'm like, here, will you take this? And if they know, okay, I have a pen in my hand, right? If they know this is a pen and they know how to orient it as a pen, I'll maybe say, can you copy this box? Can you draw me a clock? Whatever, right? If I give them the pen and they hold it in the right orientation, right? I give it to them and they take it and they know what it is. If it's a toothbrush and I give them the toothbrush and they know how to hold a toothbrush, or if I give them a spoon and they know how to hold a spoon to feed themselves, that gives me a very certain level that a person is. If they can hold and recognize a tool, like a spoon, a fork, a knife, knives go first, but something in their hand, they should be able to feed themselves. If the person has lost that ability to hold or recognize a tool, an outside thing, more likely than not, the only thing that they will be able to feed themselves is typically finger foods, right? So think little kid growing up, right? What's the first thing that children fairly start to do independently? The first thing a baby will do, I'm not talking about necessarily, the difference between breastfeeding and bottle feeding, that's not the conversation. But one of the first things an infant, a child, will do is hold a cup or a bottle and hold it and drink, right? That's one of the first things that they will do. What's the second thing that a child, as they're developing, will start to be able to do independently? Put them in a little high chair, and what do? We give them a whole bunch of Cheerios, right? Cheerios we can pick up with our fingers and eat. So if we don't know that we need a tool, if we don't know that a tool even exists, we're down to finger food. If we're not doing finger food, somebody needs to feed me, okay? So back to Miss Lisa's question, what we did in a nursing home, because end-stage dementia, weight loss is a significant problem, what we do in a nursing home is frequently a trick that is used is whatever the food is, you throw a little bit of sugar on it, a little bit of honey, a little bit of sugar, make it sweet, okay? And so then if you're needing to feed somebody and it's sweet, they're more likely going to taste the sweet and then they will take and eat it. So yes, people's taste buds change, Lisa. So yes, the things that they always liked to eat, they may not like at all anymore. For me, I've always said, do not give me gravy. Don't give me gravy. I hate gravy. Soggy food. I've got some tactile issues. Don't. Nasty stuff. So, but maybe when I'm going through this process, maybe I won't care anymore, and then it'll look really odd to my family who I've always said, don't give me soggy food, and now they give me soggy food and I like it. Who knows? So people's taste buds change, people's interests change as they're progressing through this disease process. So we have a couple more minutes. Does anybody out here live have any questions for me, particularly right now? I've had some questions from Cheryl, gave me some great questions. Thank you, Cheryl. Lisa gave me some good questions. Diane, I'm so thankful for your questions. Yet again, this is, my name is Lizette Kluta, OT. I am an occupational therapist by background and training. I have a private Facebook group called Think Different Dementia Education Group, where I do another hour-long program once a week to do topical things, where I'm in the process of hopefully expanding that out and trying to come up with more ways to serve you. If you're watching this on the replays, please throw in their replay. If you're watching this live, throw out their live. Thank you for joining me today. I invite all of you to join my group. I really, like I always joke, it's a supportive group, but it's not a support group. It's not designed to be a support group. I truly try to put educational things out there. I'm hoping to grow the group. I have a goal of 500 people. by actually the end of the month, which I don't think I'm going to quite hit that goal because we're at 433. By the end of the year, I'd love to see the group be about 1,000 people. I invite you guys who are watching this to let your family members know that are supporting whoever you're supporting as a loved one, to please join my group so that everybody can be on the same page. So all you guys are getting the same information. I know how hard it is to walk this journey. I walk this journey with you. I'm not only a therapist, but I am a daughter of somebody who has dementia. And so I use my personal experiences. I use my personal experiences as work professionally. I am a Skills to Care certified occupational therapist. There are less than 100 of us in the country, so I use my background in training to educate. So I truly do invite you to join my group. I love to teach. It's my passion. I love serving you guys. I'm here once a week. I give up my time once a week as a volunteer. This is my volunteering activity to answer your questions. Please, if any of you, if any of you live still have a question for me, please ask me the question. I think I answered all of the questions that were in the group, in the event calendar. I might have missed one because I think another one came on. But anyway, this was The Baffled Brain, Demystifying Dementia. Today is July the 24th, 2021, and today's episode was brought to you live from Tulsa, Oklahoma. And my daughter and I are going to go have some fun now. I do thank you for joining me. Thank you so much. Like I said, join my Facebook group, Think Different Dementia Education Group, and invite your family and friends into the group as well. I'm trying to grow the group so that I can continue educating you guys. And like I end all of my programs, the Lord bless you and keep you, and I pray for all of you guys all of the time. I get to know some of you a little bit through this medium, so I'm here for you. Message me if you have questions, and thank you for being here today. I'll see you guys next week. Bye. Now if I can find my button, right?